Hey guys, my name is Matt Goebel. I'm an ER resident at Bay State Medical Center, and this is part 2 in a series on getting better at EKGs. In part 1, we talked how to get better EKGs, how to get a really pristine, high, technically correct EKG, and we'll put the link to that down in the description or in a card off to the side here. In part 2, we're going to be talking about reading EKGs better. There's 4 parts to this: timing, measuring ST segment changes correctly, looking for changes in contiguous leads, and looking for reciprocal changes. Now you may think that timing belongs in how to get EKGs, but I think you'll see why I put it here in just a minute. So let's talk about timing. In this EKG, we have an obvious inferior STEMI, and in this repeat EKG on the same patient, just 4 minutes later, the STEMI's gone. What happened in between? Well, we gave the patient vasoactive medications, but this can also happen completely on its own. How often does this happen? Well, in this study, they looked at exactly this. How often does the STEMI go away on the repeat EKGs? Anywhere between 1/3 and 85% of the time. That's a lot. Now, the patients where the ST segment elevation goes away, they had just as bad blockages, but their treatment was delayed. And you can imagine why, because if the ST segment goes away, that patient's probably not going to get the same rush triage that we give STEMI patients that still have those ST segment changes when they get to the ED. So the lesson here is to get your EKG earlier and prior to any treatment. Timing is everything. We must go faster. So my first recommendation for you here is to get your EKG with the first set of vital signs. And I want you to start thinking of an EKG as another vital sign. So speaking of treating it like another vital sign, what about repeating the EKGs? So in this study, they asked medics to get 3 EKGs, one when they were on scene, one just as they were initiating transport, and one as they were pulling into the ED. They found about 85% of STEMIs on the first one, which is good. They found 94% of STEMIs by the second one, which is better. And they found 100% of STEMIs by the third one, which is great. So think of EKGs as another vital sign that you need to reassess. Just consider getting 3 of them. One when you're on scene with your first set of vitals with the patient, another just as you're starting to initiate transport and you're en route to the hospital, and one as you're pulling into the hospital. So let's talk about measuring ST segment changes. There is a standardized way to do this, and that's what I'm going to teach you today. There's 3 things you need to look at: the J point, the ST segment, and the TP segment. The ST segment is the part that we're most interested in, but we have to pick a spot on the ST segment, and that is the J point. The J point is where the R wave or the S wave starts to turn into the ST segment. So you're going to pick one spot that you're going to measure the elevation at, and you're going to measure that compared to the TP segment, which is the flat isoelectric part of the EKG where between the T wave of one complex and the P wave of the next. So let's practice this. Pick your spot where you think the J point is and compare it to the TP segment on this EKG. You should have gotten about 3 millimeters. Let's do it again. Pick your spot, pick the line. Again, it's about 3 millimeters. Now this one's tougher. Pick your spot, find the line, do your measurement. It's about 2.5 millimeters, 2 to 3 millimeters. Again, this one's kind of debatable because that rounded appearance there. Here's another one. Pick your spot, find the line, about 1.5 millimeters. Now let's do depression. You're still going to pick your spot, find the ST segment, decide where it's starting to turn into the ST segment, find your spot, pick it, compare it to the line, 1.5 millimeters of depression. 2 more quick examples. Find your spot, find the line, take your measurement, 2 millimeters of depression. And last one, find your spot where it's starting to become the ST segment, find the isoelectric line. This one's about 2.5, 2 to 3 millimeters. So now that we're accurately measuring the ST segment changes, we need to know the significance of which leads those changes are occurring in, and that's where contiguous leads come in. First, we need to understand a little bit about what the EKG machine is actually doing. we're used to seeing the EKG like this. But what the machine is actually storing and doing is this. It's recording a rhythm strip for each lead for the whole 10 seconds and then chopping it up to get that printout that we're used to seeing. So how do we get from this to that? Well, we start with the rhythm strips, and it's going to show us leads 1, 2, and 3 like we're used to seeing them for the first few seconds. Then it's going to switch and show us AVR, LNF for the next few seconds, and then it's going to switch and show us V1, 2, and 3 for the next few seconds, and then V4, 5, and 6 for the last few seconds. So you've got your EKG like this, and this is essentially 3 rhythm strips, one on top of another. So these 3 beats are all the same beat. They're just being viewed from 3 different perspectives, which, being from 3 different perspectives, takes us to the concept of contiguous leads. Contiguous leads are anatomic leads that are looking at the same part of the heart. So from this diagram, you can see that 2, 3, and F are our inferior leads because they're looking at the inferior wall of the heart. You've got 1 and AVL, which are looking at the lateral wall, and then you've got V1, V2, septal, V4, V3, V4, anterior, and also V5 and V6, also out there on the lateral wall, looking at that part of the heart. This is how those get laid out on the paper printout that we're used to looking at. There's lots of mnemonics for remembering which leads are in which regions, but this is something that you just need to memorize, unfortunately. So now let's talk about reciprocal changes. So we're doing the EKG at the right time. We're measuring the ST segment changes accurately. We're seeing ST segment changes occurring in the same leads that are looking at the same part of the heart. And then the reciprocal change is what really clinches the diagnosis that this is a STEMI. Reciprocal changes are the relationship between ST elevation in 2, 3, and AVF and anywhere else in the heart, but mostly 1 in AVL. So if you have elevation in 2, 3, and AVF, you would expect to find depression in AVL and vice versa. If you have depression in 2, 3, and AVF, you would be looking for elevation in 1 in AVL. So in this EKG, we see depression in 2, 3, and AVF and elevation in 1 in AVL. So we have reciprocal ST segment changes. In this EKG, it's a little more subtle, but there's still clear ST elevation in the inferior leads and ST depression in 1 in AVL, the high lateral leads. And in this subtle EKG, we can see clear depression in 2, 3, and AVF, and then you can just start to make out that subtle elevation in 1 in AVL. So to review, get your EKG with your first set of vital signs. And speaking of treating this like a vital sign, get repeat EKGs. Get one when you're first with the patient at bedside, get one as you're starting to come in route to the hospital, and get one just as you're pulling in. You're going to measure your ST segment changes compared to the TP segment. And you're going to be looking for ST segment changes that are occurring in contiguous leads, because those are looking at the same area of the heart. And you're going to be looking for reciprocal changes, because that clenches the diagnosis of STEMI. Thanks, and we'll see you next time.